everyone. Welcome to this CE seminar presented at the OR Manager Conference 2020, entitled Pressure Injury Prevention Throughout the Continuum of Perioperative Care. Our continuing education provider is Fiedler Education, and the funding has been provided by DeBeer Surfaces. To receive credit for this course that you guys are taking, you need to make sure that you register via your electronic device or computer by using the link provided on your screen or by scanning the QR code with your smartphone. Once you reach the site, make sure to select the sign on to launch the course. It's really important to understand that you guys only have 2 weeks post this presentation to register to obtain your guys' CE credits. Towards the end of the presentation, we will spend a few more slides, or actually there's a few more slides that are left on there, and we'll talk about giving better instruction on how you guys can do so. Well, there I am. My name is Tricia Skirvin. I am the Regional Clinical Manager for DeBeer Surfaces. I have been a registered nurse for 15 years. I've worked in various areas of acute care, anywhere from ICU, labor and delivery, as well as the operating room. The last 9 years or so of my career, I have been working in industry, primarily focused on pressure injury prevention and treatment. I'm also wound care certified, and now I work for DeBeer Surfaces as a regional clinical manager. So some objectives today that I'm going to be going over with you guys as far as pressure injury prevention in the OR and the continuum of care. We're going to identify the etiology of pressure injuries, as well as some risk factors for development of PIs throughout the continuum of perioperative patient care. We're going to discuss some ways on how to assess for pressure injuries in each phase of care, as well as describe some interventions, including new technology that might help reduce the risk of PI development originating or progressing throughout the perioperative patient care. Important fact I'd like to highlight for you guys here, every year there are about 2.5 million patients developing hospital-acquired pressure injuries. The cost to treat a HAPI is upwards of $26.8 billion each year in the United States. That equates to patient care costs from one PI anywhere between $20,000 upwards of $151,000 per pressure injury. And about 60,000 deaths, patient deaths related to HAPIs occur each year. Here's some background information on some pressure injury. Safety concern for patients and healthcare professionals. HAPIs are considered never events every time in the hospital. And it's important to understand that hospitals are not reimbursed for any stage 3 or stage 4 pressure injury during a patient's stay at the hospital. What exactly is a pressure injury? Well, it's a localized damage to skin and underlying soft tissue. Pressure injuries typically always occur over a bony prominence or anything that is related to a medical device. So anything that could be underneath the skin, not necessarily on a bony prominence, is related to that medical device causing increased pressure. They can present as an intact skin or an open ulcer. This says may be painful, but I always like to say that they are usually always painful for the patient. And it always occurs as a result of intense and or prolonged pressure or pressure in combination with shear. Causes of pressure injury. So this basically is going to go into different steps for you. So the first step would be, obviously, patient would have to have prolonged pressure on a bony prominence. So the pressure is between the surface of the bed and the bone, which may be greater than the pressure of the blood flowing in the capillaries. I like to explain this as almost like a garden hose. So patients laying in a position for a long period of time, that 20 minutes, and that's that kind of key where the interstitial pressure cuts off blood flow to those vital capillaries. It's almost like a garden hose. At this point, it's going to cut off that circulations, and those blood vessels are unable to deliver nutrients, which render cells and tissue damage that vital oxygen that they need. So prolonged pressure, patients are in that same position for a very long time. Can upwards be, 2 hours as early as 20 minutes. Friction, this is resistance to motion This occurs when patients are being transferred from, say, the gurney to the OR table, or the OR table to back to the gurney or the bed. Shear, this usually occurs a lot of the times in combination with friction. It's when two surfaces move in the opposite direction. So if you can see my hands, it's almost like when you're sliding a patient up in bed, or you're moving a patient, you're positioning that patient. That's when shearing a lot occurs. It pulls the skin in opposite directions as the head slides down the bed and the tailbone moves. So think of it as if a patient is sitting up in a high Fowler's position and that patient starts sliding down the bed. That's a good indication, or a good example of shear. Excessive moisture always contributes to pressure injuries. The patients are sweaty, they're diaphoretic, there are lots of things that are happening in the OR that's making them, excessive moisture. Sometimes on the floor, urinary incontinence, those sorts of things. All of this in combination cause a high rate of a PI development for a patient. Why the OR? Well, there's long periods of immobility for patients in the OR. It's really difficult to position the patient once they are strapped in and intubated and surgeries have begun. That high risk, exposed to friction and shearing, like I said, we're moving the patient can't move themselves, so we're doing it for them, and the high rate of patient comorbidities that they come in with. Who's at risk? Well, all perioperative patients have some risk of PI development. We're going to go over some risk factors, some intrinsic as well as extrinsic factors for patients that are coming in for surgery. So some intrinsic factors, some that pre-op might discover: patients' ability to tolerate pressure, friction, and shearing. These are affected by tissue thickness, patient condition, and tissue health and viability. Some intrinsic factors, some preoperative things as well, would be: is the patient very young or very old? All of these things make a patient high risk, or they're a good indicator to determine if your patient is high risk. The nutritional status increased with malnutrition. Obviously, if you have a BI index of less than 19 or greater than 40, the patient's had a recent significant weight loss and they've come in prior to surgery, or if they've been in the ICU and they've lost a lot of weight. Lab values is a good indication. We want to look at albumin, hemoglobin, hematocrit levels. What sort of or comorbidities does the patient suffer from? Are they diabetic? Do they have peripheral vascular disease? Any cardiovascular issues? What's their skin integrity like, including previous tissue injury? I always like to point this out because patients that have had previous pressure injuries are always at greater risk of developing a pressure injury in that same area. Their ASA classification and their peripheral pulses. Extrinsic factors for intraoperative, mechanical or environmental variabilities, how long they sustain external pressure, what the moisture issues were during surgical procedures, and how much friction and shearing, how much movement was the patient going, like basically having done during the procedure. Were you moving the patient around a lot, positioning and those sorts of things. Some more extrinsic factors: length of surgery, like we talked about, type of surgery. Cardiovascular patients, CVOR, your patients are at very high risk for PI development. Any surgical position and devices that we're using, are we putting them in a lateral position? Are we putting them in a prone position? Are they staying in these positions for a very long time? Devices used, warming devices contribute to moisture control, maybe it make a patient sweat a little bit more. Patient core and room temperature, all of these things play into moisture control. Surgical tables and pads and overlays. What are you guys actually using for your PI prevention on your tables? Anesthesia, how long they're under, any medications that they are currently taking. And we see here that we talk about cardiopulmonary circulation, which is why I said that your CVOR patients are high risk. Postoperative factors. How long was the patient in PACU? What was their hemodynamic status like when they came out of the OR? Was the patient hypoxic? Again, if you can see the pre-op kind of now plays into the post-op as far as nutrition goes. Patient, was malnutritioned after. Now, obviously, they're going to have an issue coming out of post-op with nutrition. What was your skin assessment? I want to highlight this because it is very important for post-op to look at skin once the patient comes to them, to check for any sort of redness, PI possibilities, any of that stuff. Although each area, as far as pre-op, intra-op, and post-op, we should always be assessing skin, but post-operative, we should really be looking at the patient's skin. What does it look like? Pressure redistribution, pain medication, and device-related ulcers. It can take up to 72 hours before the first signs of pressure injuries appear. This is really important because think about your patients that may have, had a heart transplant or bypass surgery or something of that sort. They were on the table for a really long time, and now they're going to go up to the CVICU. They may not develop a pressure injury for maybe 2 or 3 days. And then these are the calls that you get from your wound care nurse or risk management questioning you about kind of what happened with that patient that may have come out of your OR. That's why a lot of the times, most of the time, you guys won't see the PI, but because it can take up to 72 hours. Some challenges of identifying pressure injuries. We're going to determine what is an actual OR pressure injury. Intraoperative team, like I said, will most likely not ever see the PI. You might see some redness, but you won't ever see the actual, say, deep tissue injury or the end result of what that pressure injury looks like. Seldom visible at the end of a case. This is where it needs to be tracked downstream. So this is where I just talked about how that patient might go to or may go to the ICU or whatever ICU that they get sent to. And now they've got a skin champ or the wound care nurse gets called in, and then they want to now track that PI downstream, and that it comes to you in the OR. We're going to go over some actual pressure injuries. You guys will never truly stage these, but I like to basically tell you or to focus on the most important part of these stages that I'm going to go over is the description and the details of what you see. Very important that when you are doing your skin assessments, if you do see something, be very detailed in what you see in each one of these. So we have a stage 1 that shows right here on the top. What you're going to see with this is just reddening. The most important thing with the stage 1 is you are going to have non-blanchable skin. So you're going to press that and you are not going to have that blanching. If you have blanching, then that wound is pretty much, or that is screaming at you like, hey, I may have an issue. Get me off my side or get me off of this position so you guys can get blood flow. Very important to note if it's blanching or non-blanching in the site where you see it. The bottom is a stage 2. That would be considered a partial thickness skin loss. This is what I like to describe as, we go out, we wear these cute heels or a cute pair of shoes, and it's rubbing, and then we get that nasty heel blister. This is what a stage 2 is. Very superficial, can be fluid filled, may not be fluid filled, but it's not deep. It's very shallow. So basically what we're going to do is we're going to detail where it is, that it's open, and then over, specifically whatever bony prominence you see it on. Stage 3 is a little bit deeper. This is where you will always see fat and granulation tissue. This wound actually has some slough in it, but the important thing, like I said, to note, it's going to be deeper. You're going to see that red, beefy type of tissue in this wound. You are going to note where it is and where you see it. The stage 4 is on the right. It's a full thickness skin and tissue loss. A lot of the times in this wound, or most of the time, you will always see bone, you will see tendon, you will see muscle. This is your really, really deep wounds that you guys hear about in nursing school. Again, most important thing we want to note is what you actually visualize and then where it is, because what that does is that gives that wound care nurse or that person that's looking downstream an idea of exactly what you guys saw. But you'll never ever stage like, oh, I think this is a stage 3. You'll never do that, just details. Pressure injury often presents a lot of the times, especially for prolonged pressure on an area is a deep tissue injury. This will show up as a bruise, almost like a deep purple maroon colored bruise over a bony prominence. And this, a lot of the times, it's how they will present coming out of the OR. And even if you guys document a bruising noted over coccyx or over right ischial tuberosity or greater trochanter or something of that sort, that's perfect. Also, not just after surgery, but even if it's really important if you guys see these coming into your OR that you are noting this on your documentation, because it will help cover you if this turns around and somebody brings it back downstream, because you have documentation that this person did have issues prior to it. We're going to go over some strategies to mitigate risk throughout the perioperative patient care. Common sites of pressure injuries, where you're going to see these, 64% of these you'll always see on the sacral area, greater trochanter, or the right or left ischial tuberosities. Most of the time you will see those specifically coming out of the OR. But obviously, as you see at the back of our little display here, there are various areas where pressure or patients can get PIs. Some guidelines we're going to talk about: support surfaces, monitoring, risk assessment tools that you guys may be using or may not be using currently, communication, and some new technologies we're going to go over. So the National Pressure Injury Advisory Panel, they set the gold standard when it comes to PI prevention across the board. A lot of the times I have found that in the OR, not many people really know who NPIAP is. They, like I said, as far as acute care goes and as well as long-term care, they do set the gold standard, the precedence of PI prevention, treatment, and ways, things that you can use as far as treatments. So some things I'm going to highlight for you guys to understand and know here is they recommend use of a high specification mattress on the OR table for any at-risk individuals, which most of the time, I believe, your OR tables will have this now. I believe it's across the board. You have pressure redistribution surfaces. Ensure that your heels are always free of the surface on the OR table. And when I say heels are free of the surface, I mean offloading and actually free floating heels. This actually is the #1 way to prevent pressure injuries from occurring on the heels during surgical procedures. And I say this too, because there are some procedures that you can't allow the heels to free float, but in most, if you are able to, make sure that you are free floating by putting either a pillow or something else. Most of the time it's a pillow, and that's honestly the best way to do it, is just free floating those heels. We're going to pay attention to pressure redistribution prior to and after surgery. So those are some recommendations, some highlighted recommendations that NPIAP recommends for the OR. Some strategies for support surfaces. Consider use of a proper support surface in each phase of perioperative care. That means obviously in pre-op, what are we having them on? Where are they coming from? How long have they been in the same position? Are we going to carry it over into the intra-op as well as the post-op? Dynamic support surfaces may help decrease development of PIs. And when I say dynamic, I say I should focus on movement. So anything that moves is a dynamic support surface. Avoid using less sheets and blankets as possible for patient positioning. And as much as possible as well, we're going to try to avoid any kind of wrinkled or damp linens underneath the patient. The AURN positioning guideline recommends turning. I always like to say, the guideline recommends that we're going to turn and reposition immobile patients for at least every 2 hours to increase tissue perfusion. Now, while this is a great guideline, this is, to me, as a nurse and working with various ORs and clinical staff, it's kind of unrealistic to do so during a surgical procedure. So great guideline, realistic. I mean, we can do a little bit of micro shifts and those sort of things, but it's very difficult to reposition immobile patients during procedures. But what we can do is we can pad or offload heels. We're going to do as much padding for bony prominences and high-risk areas, as well as place any kind of prophylactic dressings over those bony prominence high-risk areas for PI development. This is a duration, basically a cumulative time effect on a patient being on a support surface. So sometimes we're very focused on what happens intra-op, how long the patient's in surgery for, how long the patient, anything greater than 2 hours, 3 hours, 4 hours, or whatever your protocol is. But I'd like to talk about cumulative time, and sometimes forget that. We have a patient that possibly maybe fell at home. She was on the ground for 6 hours because she broke her hip. And then she went to the ED and spent some time in there for x-rays. And she, possibly maybe went to pre-op and sat in there for an hour, and then went to intra-op and spent, 4 hours or 5 hours, which maybe typically wouldn't be a high-risk surgery depending on, whatever your protocols are for PI prevention. But then she now has to go to post-op and sit. So you can kind of see where I'm going with this. We've got a patient that has spent a lot of time in a certain position. So when we look at a patient, we need to look at the whole story of the patient. So clinical judgment comes into play here. Look at how long the patient's been in the same position for. It's an easy way for me to explain it versus, it's just going through and, time in ED, time before sedation, all of these things. They all come into play and they should be considered when it comes to patient and pressure injury. Some challenges of identifying PIs. Well, they're not present or visible until about 72 hours after a surgical procedure. Some ways that we might be able to identify maybe them is monitor early signs. We might be able to do some pressure mapping or some neurophysiological monitoring to see if that patient is at risk prior to it developing. We're going to go through some assessments. It's important for collaborative communication. We've got evidence-based guidelines, shared knowledge between everybody, clear understanding of various stages and signs of pressure injuries. Are we all on the same page when we're talking about what exactly we're looking at? Some standardized assessments and documentation. It's really great, if possible, to assign a champion to follow these patients from the OR that may be higher risk. Some collaborative communication. Ways that we can do this is we can make sure that we have some standardized assessments and documentation. What are we using? Are we all using the same thing? It always also begin when the patient is scheduled for surgery. So pre-op should be the very first touch that patient has as far as determining, are they high risk for developing a pressure injury during their stay or during their whole surgical procedure. Pre-op, we should also communicate highlights from our risk assessment to the intraoperative team. So if you're looking at a patient and you're looking at their chart and you see that their albumin's off, they've lost a lot of weight or they're high BMI, they're not very mobile, they do have a history of skin breakdowns or previous pressure injuries, and they've got a lot of comorbidities that put them at risk, that should definitely be communicated to the intraoperative team so then they know the steps that they need to take in order to help prevent and protect that patient. We want to create consistent awareness of risk factors specific to the patient. And then the intraoperative team also needs to report to PACU and then PACU to the unit. So it's a joint effort for that patient starting from pre-op to intra-op to PACU to unit, wherever they go. Some key elements to include, what we want to talk about is we want to talk about how long that patient was on the OR bed. The patient, say, was in a supine position for 8 hours. What devices that are used? This is intra-op, that's, communicating to the PACU team. Some skin assessments at the end of the procedure, and then also PACU would be presenting and talking to the ICU or the unit as well, kind of giving them this whole report of what happened with the patient. Specifically also including time in the PACU. Feedback loop to the OR team is if the patient develops a PI, so the OR team can investigate it as well. Most of the time, you guys are going to hear that the patient, like I said, went up to the ICU and then 2 days later now has a pressure injury. A lot of the time, wound care will notify that specific person in your area, letting them know that they have a PI. And then also there should be some sort of feedback loop if a PI develops after discharge. A lot of times, just because a patient comes in for outpatient surgery doesn't mean that they don't develop a pressure injury. So there should be some sort of a feedback loop that gets set up so everybody can be on the same page for that. Some risk assessment tools that you may or may not be using. We've got some things, we've got 3 things that we're going to go over here. Some hospitals use Braden scale, some use Monroe scale, and then some use the Scott-Triggers tool. The Braden scale is, it's not so much widely used in the OR, but I have had accounts and hospitals that do use it in pre-op to kind of, well, I shouldn't say kind of, they do determine whether a patient's going to be high risk using this. The issue with this is it's low predictive validity for a surgical setting. This is not a surgical assessment tool. This is I don't even want to say a great assessment tool, but it's a assessment tool that the floor uses or the WOCN uses to determine if a patient needs a specific support surface up on the floors. So, and it's beneficial to assess older adults and how at risk they are. Very subjective in my point, or in my position, I think. The Monroe scale, this is a very much OR specific scale. It evaluates the risk associated with the patient care in each area of perioperative department. So your periop, your intraop, and post-op is going to use this scale throughout the patient's procedure. Some things include a patient's current skin condition, what are their comorbidities, their ASA classification. Again, if you see a coincidence or a theme here, we're talking about all the things that put a patient at risk. The Monroe scale looks at your lab results, core temperature, how long the procedure goes. These assign them a number and then they are scaled based on that. Scott-Triggers is a good down and dirty, basically 4 questions. This is typically tested in the preoperative department. It examines 4 areas, so patient's age, BMI, ASA score, as well as time of surgery. If they answer yes to 2 or more questions, they are deemed high risk. So like I said, this is a quick down and dirty for pre-op to do. If there's not a lot of time, they can look at this. These are very easy questions to answer. 2 out of the 4, they're immediately high risk. Some interventions and technologies to help reduce risk for patients. Staffing. So it's great if we have adequate numbers of perioperative team members in the OR during positioning. Like I said, I was a nurse. A lot of the times we didn't have as much staff, but it's awesome if we can get as much staff in that OR as far as, preventing dragging that patient, sharing, tearing, friction when we're doing any kind of positioning. That is the ideal scenario. Patients may be induced with obviously anesthetic on a stretcher and then are moved to the OR bed. So we want to make sure that we're utilizing as much staff, any kind of devices, any kind of air transfer, any of that stuff that would help decrease friction and shearing. It's also important to make sure that we ensure proper alignment and to place devices to prevent damage to the skin and bony prominences when we're positioning our patients. We're going to go over some technologies and devices, which are all continually evolving. Everything changes very quickly in the medical device world. So foam dressings, everyone is typically, we're all aware of the 5-layer foam dressings. Most of the ORs are using these for PI prevention over bony prominence areas. These are traditionally used to prevent PIs by placing these 5-layer foams on high pressure areas of the patient's body. So think about, you guys are putting these on your sacral areas, sometimes your heels, if they're in a lateral position. Most commonly placed, obviously, sacrum and here's, like I just said. Can be effective In preventing pressure injuries, I'm going to highlight in the short term. Remember, we talked about that 20-minute area where after 20 minutes, we start to increase interstitial pressure and those blood vessels like a hose start to clamp off and they're not able to deliver oxygen. So this is effective in preventing PIs in the short term. For longer surgeries, they can roll or become detached. So think about if you're moving and you're repositioning your patients, sometimes they come off. If you're rolling or they do roll, that could cause increased pressure. They can also have a negative impact on the integrity of the patient's skin. Some of them are really sticky, and these elderly, folks have very fragile skin, so we have to be careful. Bandages may be considered more cost-effective than a traditional support surface per unit. And also, the flip side of that is actually they can become more expensive on an annual basis because you're using them, several of them at a time on patients. And if you're, turning and burning surgeries all day long, think about how many 5-layer foams you're going through at a time. Pressure redistribution devices. These increase surface contact area. The most common tool, these are actually the most common tool used as a risk reduction strategy. The limitations for using a pressure redistribution device is that they do not offload and they increase inner surface pressure throughout the time the patient's on them. So again, that hose clamp that I talked about earlier, that hose closing off. Offloading means you're not getting that specific alternating pressure where they're offloading at interval times. Static pressure redistribution devices. These can be mattresses, overlays that provide additional pressure redistribution. So again, we're redistributing those areas over the bony prominences, high risk. Think of these as your gel pads, your viscoelastic mats. Longer duration of procedure may lead to bottoming out. So your sacral area kind of hits that bottom on that gel pad, and then you're increasing your pressure. Your overlays could also be foam pads, static air, or gel. And when I say static air, I mean there's no flow. It's almost like a pool raft. So think of static air as zero change in pressure. And then anything dynamic has movement to it. Here we have a dynamic pressure offloading surface. Alternating pressure. So this is a low profile support surface. You can apply it to the OR stretcher or to an OR bed. Alternating pressure is basically you're having inflation and deflation of certain areas, zones, baffles, whatever you want to call it. Inflate and deflate on a timed cycle. So this is, you're getting offloading in these particular areas. So your sacral area or IST that might be heavy and they might be sitting in those longer positions. You're getting active offloading and repositioning and allowing for that blood flow to come through and actually reperfuse those bony prominence areas. Some characteristics to consider for a product selection when you guys are looking. We want to make sure that we distribute the body weight across many small points of alternating contact. So you can see the little man on the side. We want to target key circulatory components of arterial, venous, and lymphatic blood flow. We want to account also for specific patient BMI when we're looking at these products. Some patients, the BMI or products may only go up to a certain BMI, whereas others, go over that. Include mechanisms to reduce skin shear and pressure. If you see on the bottom too, this would be an actual sacral area, and they got a zone 1 inflated, zone 2 deflated, and that will actually show you your offloading and your pressure redistribution. Education and awareness. So we're going to be knowledgeable in AOR and standards and guidelines, NPIAP perioperative guidelines. We are knowledgeable now in collaborative communication, some standardized assessment tools. It's great if we have the ability to assign a champion to follow high-risk patients. And when I say a champion, I mean somebody that's in the OR that is in charge of following these patients, that may be at high risk for pressure injury development. So these might be your people that help determine and set that PI algorithm, that pressure injury prevention algorithm, your PIPs. Usually those people are the ones that are great champions to follow and communicate with your units and your wound care team. We have some awareness of new technologies designed to reduce your patient's risk. Okay, so this is where we need to talk about more about how to actually register to receive credit for this course. So what you're going to do is you need to visit either this link, which is the virtual course registration link, or if you have, most of us have cell phones, if you can take that QR code, take your camera and actually snap a picture, or go to your camera and take that picture and go to the link. You're going to go, if you do it that way, it's going to take you to the registration link above, and then you're going to select sign in to launch course. It's going to take you to Fiedler's education website. Step 2, we are going to make sure that we sign in. If you have a Fiedler account, this is great. You can just go ahead and sign in to your account. If you do not have a Fiedler account, make sure that you create one, and it's free. So it's free to create the account. The important thing is this is where you'll be able to access your certificate of attendance. So all of your stuff is going to be stored here. So make sure to sign in or create a free account. Step 3, we're going to launch the course. So when you scan the QR code or you go to the link, you're going to launch the course, and it's going to say, you'll see the course title, and you're going to launch the course. Course material are located under the resources tab on the top of the evaluation. It is important too that you guys take the time to fill out the evaluation for this presentation. And then what you'll do is you'll fill that out, and then you will close the window. Let me go to the next one, where we talk about the actual filling out of evaluations. Getting ahead of myself a little bit. You're going to complete the evaluation. You're going to close the window to return to the Fiedler Education homepage. So once you complete the evaluation, you'll close the window. What you'll do is you'll go to certificates of attendance available after completion under the My Learning tab. So it's pretty easy. You just have to follow the steps to go through the process. Make sure that as of 2 weeks starting today, the time is ticking. The deadline to register to obtain your CE credits the deadline for registration is October 14th. So time starts today, 2 weeks from now. If there are any questions or concerns, you guys, please don't hesitate to contact Fiedler Education. Their number is listed right there on the screen, but I can tell you it's 720-748-6144. And I think we are finished. So I want to thank you for taking the time to take this CE education presentation. If you have any questions, please note them in the comments box over on the chat screen. Put your questions in there. I am more than happy to answer any questions that you guys may have. So I will wait to see if anybody has any questions. Looks like we don't have any questions. If you have any questions later, you can message me directly by going to our DeBeer Services booth or visiting our DeBeer Services virtual booth and starting a chat there, and we'll be more than happy to answer any of your questions. But I'll wait.